Welcome to the Infection Prevention Strategy Tips Masterclass, Candida auris and Biofilm, Proactive Measures for Mitigating Fungal MDROs. We will get started in a few minutes. Welcome to the Infection Prevention Strategy Tips Masterclass, Candida auris and Biofilm, Proactive Measures for Mitigating Fungal MDROs. Your lines have been muted. The learning objectives for today are posted on the screen for your convenience. My name is Dan Mueller. I'm the Senior Vice President with Curcia Healthcare and TIPS Advisory Board member. The presentation will last 50 minutes, followed by 10 minutes of Q&A. Please type your questions in the Q&A panel. The webinar series is hosted by TIPS. TIPS is a non-for-profit that exists to advance innovations, ideas, and processes that make a difference in global health. TIPS extends to over 30 countries and is the key strategic partner for many notable organizations, initiatives, and events. In the past few years, TIPS has contributed millions in scientific impact. Note our disclaimer, please consult with your local government and regional health authorities for specific instruction on all topics mentioned in this webinar. Our sponsors today, ISSA Canada and Eviclean. Eviclean Next Generation Infection Prevention Solutions provide EPA-registered disinfectants, the Protexis electrostatic sprayer, wipes, and the Pure Excellence program. They have comprehensive programs which target process improvement, safety, and cost reduction. Introducing today's speaker. First, really excited to have Dr. Rodney Rohde. Dr. Rohde is an advisory board member of TIPS and professor, research dean, and chair of the Clinical Laboratory Science program in the College of Health Professionals at Texas State University. He's been recognized with teaching excellence at both Texas State and Austin Community College. Rodney is a frequent keynote speaker traveling across the country, and he just landed last night on one of those trips. Our second speaker is Nicole Slalick. Nicole leads the Eviclean Education Program and on-site clinical trainings for health system nationally with a focus on increasing patient safety through standardized cleaning and process improvement. Her contributions to the implementation of infection prevention programs have helped healthcare partners achieve and retain the highest leapfrog hospital safety grades. Nicole is also founder of Bextera Health. And at this point, we're going to have Rodney start with his presentation.
All right. Good day, everyone. It is a joy and a pleasure and an honor to be here to talk to you today about our topic on Candida and other related areas. Just going to get started here with Candida auris. If you're not familiar with this organism, I'm sure many of you are. It is a fungus that can cause serious infection. Typically spreads patient to patient, but it can also be an issue with the environment that we'll talk about a little bit today. If you don't know about Candida as a genus, there are other types of species within this one. Many of you might know that candidiasis is something that can cause a typical yeast infection in the reproductive area for females, and it can also cause other types of infections from different species. This particular species can also be a colonizer, so it's even on your body, even if it's not something you see in particular areas of the body. So when hospital and nursing patients are colonized, they may actually allow that spread into their bodies through perhaps an indwelling catheter, for example, or something else that allows that bug to be spread to other people around them. Here is a look at Candida, kind of a broad look over the last few years. One of the major things you should know is that Candida auris is now at an urgent threat level. Both WHO and CDC has deemed it that. There have been hundreds of cases over the last few years, and each year which has been on a steady rise since 2013, 2012, kind of that time frame. 90% of the isolates have been found to be resistant to at least one antifungal, and a third of the isolates are resistant to at least two antifungals. So basically, if you get the infection, you could run into a situation where it's very difficult to treat. So that's why prevention of this infection is so important. It is an emerging multi-drug resistant yeast, and it can cause all sorts of problems, especially in immunocompromised and people who are very sick. It was first identified back in the early 2000s. Auris actually means ear canal, and that's where it was first identified. And it will typically be resistant to many healthcare disinfectants. And as I mentioned earlier, since it's a colonizer, you may not even realize you're carrying it, and you can spread it around the facility you're at. If you look at the annual reporting since 2015 to 2017, you can also see the extensive increase of 300 and almost 20% of cases when you compare it back over the earlier years. So that has been moving forward. This is a slide that shows you the CDC's 2019 antibiotic resistance threats report. You can find this full report on CDC's website at the link listed. And what this is determining now is that we are seeing, and this is not really a surprise if you're in the world of microbiology like I am, is that we're seeing different strains, different variants, depending on the language you're looking at in the literature. But you can see how a variety of these Candida auris strains are popping up in the United States as well as globally. Nationally, this is a heat map. If you haven't seen a heat maps basically mean the darker the color, i.e. the hotter the state is with cases. So this is showing you the number of C. auris clinical cases up through the end of 2022. Like most infectious disease data, it's often lagging because you're waiting on that data to come clean after a few months past the year. So we don't have 2023 total cases yet. You can get 2023 data if you look month to month. But you can see here that many states, California, Nevada, Texas, New York, Illinois, Florida, are what we would consider, warmer, or a few more cases per year. And then the other states are light gold or orange, showing a steady climb in cases. So this is absolutely being detected across the country. We think that's many reasons for that. Probably poor general infection control and prevention practices in healthcare facilities. And that's not really a slam on any one particular place. It just means that truly through the COVID pandemic, we think that perhaps some of those measures may have fallen off a little bit, and that may have allowed that increase to occur in cases. It's also concerning that we're seeing it spread globally, but I can tell you that when you have increased case counts, it also may be a factor of enhanced efforts to detect those cases. In other words, many of us that are in the world of infectious disease know this, right? So kind of the old saying of, if you look for it, you will find it. And so that's a factor to keep in mind as well, because many times when you're actually got those assays together and you're looking for a particular bug, you start seeing them. There's also been increased colonization screening. So what does that mean? That means if a patient's, for instance, coming into a nursing home or a long-term care facility, then you may detect it as a colonizer. And so that has also helped, raise attention and detection. Very, very important with respect to kind of understanding the statistics around seeing this drug-resistant bug. This is a study, a really important study that was conducted in the Midwest in 2021 in a skilled nursing facility study. So I'm going to show you several studies today that kind of document Candida auris and where we're seeing it and some of the effects of that. And this was a positive correlation between C. auris skin colonization, so what's being found on the skin colonization, as well as what's in the environment. And this was at a ventilator-capable skilled nursing facility in the Midwest. The samples were collected in a 70-bed unit a ventilator capable unit of about 300 bed skilled nursing facility between March of 2017 and October of 18. The first C. auris colonization case at this facility was identified in March of 2017 during what's known as a PPS, or a point prevalence study or survey. And they did that using primarily culture. I'll talk a little bit more about that in a moment. Culture is when you actually grow the organism up and perform different tests to identify it in the microbiology lab. And then throughout that study period until September of 18, the hospital documented a rise using that culture method in C. auris colonization with a prevalence of about 71% on that ventilator capable floor. This is a study that was presented at SHE this past, or that's in the spring, not long ago, April 11th through 14th in Seattle. And this is a study that's really looking at poorly cleaned equipment as perhaps being the first pediatric cluster of C. auris in the United States. So the investigators felt that C. auris cases was likely caused by shared mobile medical equipment that was not properly sanitized after being used for adult patients after their investigation. So many of you know, in the world of infection prevention and EVS, and even in the world of microbiology and infectious disease, that shared medical equipment can be a common vector or vehicle for these types of outbreaks to occur. So it just really shows and reaffirms the reason to watch for that type of vector and how to properly clean them. They noted lapses in knowledge and practice for the cleaning and disinfection of medical equipment shared between those units. Remember, adult versus pediatric. And they isolated C. auris from that equipment used by adult patients, even though it was designated as being clean already. So that just shows us, again, kind of the ongoing effort that facilities need to take action in a timely manner if they detect cases, and strengthen their infection prevention and control practices to try to minimize that type of introduction of any microbe, not just C. auris. So why is this so concerning? We've already mentioned that recent strains of C. auris have been shown to be very antifungal resistant. We know they can spread rapidly in healthcare and long-term care environments for a variety of reasons. Remember that you're really talking about people who are vulnerable because they're sick, or they're immunocompromised for any number of reasons, including age. Age is also an immunocompromised state. And then the perfect storm here is that the bug can persist in the environment for longer periods of time. We'll talk about that in a moment. We've seen that it can have a high mortality because many of these strains are antifungal resistant to 2 or more antifungal drugs. And then you can throw in on top of all that it's not the easiest organism to do a routine lab diagnostic for or to identify. So there's some issues there that we'll talk about. Like many things, unfortunately, C. auris can include symptoms of high fever and chills, among other things. And this is a very common sign that your body's fighting some type of infection. And so if you don't have a proper diagnostic or a proper identifying test, a physician may empirically treat with antibiotics. And so what does that mean? Well, that means antibiotics are not useful typically against fungal infections or viral infections. You really need the right bullet for the right bug, and antibiotics don't work well against viruses. They're really, or fungus, or protozoa. They're really focused on bacterial infections. So this is a sign, and this is a hint to physicians, that if you are treating a nursing home patient, for example, or an ICU person with antibiotics and they're not getting better, then it's possible that Candida auris may be the cause, or again, it could be a virus or something else. So they're very similar in symptoms to other types of fungal infections, and actually other types of microbes as well. Also remember that many people who have these infections are already very immunocompromised or really sick. And so sometimes it's hard to tell apart from other symptoms. It absolutely can be mistaken for a different type of fungal infection unless special lab tests are used to identify it. That's a true statement for me in many cases across different classes of microbes. I always tell people, without a medical laboratory test, your doctor is just guessing. And that's an appropriate thing to say, even though I have great respect for physicians and others. You really don't 100% know unless you have identified it through a medical laboratory test. And it's the perfect thing for us to remember this week because it is Medical Laboratory Professionals Week. So look at this down the left-hand side. Now, if you're not a microbiologist, let me try to explain this a little bit. This is showing you different types of identification methods. This is a BITEC. This is an automated type of method. These API are different types of semi-automated methods to identify different yeast or other types of organisms. These are the BD, Becton Dickinson Phoenix Yeast ID system. Microscan mimics BITEC, and Rapid ID Yeast Plus. So all of these are supposed to help us identify yeast and other fungus, but look at what C. auris can be misidentified. Notice that most of it gets to the genus level, but it misses the species. So you're getting, Intermedia and Saki and Campanulata and all of these others, Parasolopsis, all these others that are different species. We've also got an oddball here, Rhodotorula, which can show up, or Saccharomyces, which is the genus of beer. So they're not perfect is kind of the take-home message. And so sometimes, again, as I will tell the public and my colleagues and friends, if you're taking a particular drug or things are not getting better, even if you thought you had the right identification, you may need to get a confirmatory test, perhaps a molecular-based test or something that's more stronger to identify. We do have differential media. So these are different types of media produced by Chromager. It's actually called Chromager Candida. And what basically the take home here is that in the microlab, we have very nice differential medias that we can use to help screen for certain types of organisms. They turn different colors on this media. They have different chemicals in the media that only Candida can ferment, for example, and you end up with different colors. If you're really fortunate, it works really good with different species. And you can kind of see here on the middle slide, some of the circles here showing you that depending on the species, you might see glabrata, which is purple, tropicalis is navy blue, and auris is white. However, sometimes you'll see on the right that it's not perfect because you can get different color morphologies, even though this is C. auris. So it really takes a trained microbiologist, medical lab professional, and even they sometimes can be tricked by these more semi-automated or manual types of methods. They're still useful, but sometimes you have to follow that up with a confirmatory test to kind of prove what you have. It's not typically diagnosed with standard test methods. You might be ordering a complete blood cell count with differential to look at the different cell types being involved. You might order blood cultures if the person's septic or you're concerned that they're septic. You're typically going to do a basic metabolic panel. And then this last bullet is a specific type of test for fungal identification. So different fungi will ferment different types of sugars. And there's quite a few of them actually. And so that's part of our arsenal to try to identify a particular species. Okay, guidance for detection of colonizations. Remember, colonization is not infection. Colonization means you found it somewhere on a body, but it's not actually causing an infection. So CDC would like you to report all confirmed C. auris specimens to state and local departments and CDC. There's some information about it at the top. Real-time PCR is a great opportunity to confirm things. So if you have those resources, real-time PCR, sometimes you'll see that written as little q PCR, which means quantitative PCR. It's an accurate method for detecting C. auris in real time. really quick turnaround time. So that's a really useful test. You've heard a lot about PCR during the COVID pandemic, and PCR continues to be one of the better tests for rapid turnaround and usually stronger identification. If that's not available, then we can get into culture-based options, which means growing it up and then doing some other types of some manual, semi-automated, or other automated systems to try to identify it. Again, with some loss of sensitivity and specificity when you're doing that non-real-time PCR test. This is a look at a study of a screening pilot in select units of New York City healthcare. So this was in the American Journal of Infection Control and out of APIC. Basically, they implemented this admission screening in healthcare facilities in New York City. The highest C. auris colonization rates and admissions to nursing home were ventilator units. That kind of makes sense with respect to the typical medical device that can spread a number of microbes. They found that admission screening can absolutely be a part of a strategy to identify C. auris colonization. Sometimes this is also done for MRSA or C. difficile to try to prevent those nasty organisms from getting into a healthcare system. IV is absolutely important to help lower the risk of transmission in those high-risk settings. Again, thinking ICUs, thinking nursing homes, thinking pediatric wards, maybe organ donor wards, and using that real-time PCR testing to rapidly ID C. auris as appropriate transmission-based precautions and control measures to kind of help you to rapidly identify transmission risk. Again, this depends on the resources of different healthcare systems. Sometimes in rural settings or places that aren't in level 1, level 2 trauma centers may not have access to high-level molecular testing just out of pure economic decisions. Here's another study looking at the Journal of Hospital Infection. Really the first experience of implementing Candida auris real-time PCR for surveillance in the United Kingdom, and detection of multiple introductions with 2 international clades. A clade is a kind of a sequence or DNA-based identification that helped improve patient outcomes. And so what they did here is they again took that real-time PCR assay for C. auris, is developed, validated, and implemented for direct use on skin swabs and urine. They also did environmental swabs as an emergency outbreak control measure. Sequencing was performed using a particular type of sequencing from Illumina, and they put together maximum likelihood phylogenies. What does that mean? That means they statistically compared isolates from different places and different sites and see how much alike they were. This is what we typically do in surveillance to try to figure out strains and variants. 21 C. auris colonized patients were identified. Look at the turnaround time. It was reduced from 141 hours, almost 6 days, to about 1 day. That's really a significant improvement to help knock down those infection control practices. And despite being in a high-risk setting, no patients fortunately developed invasive infection. That's always a great thing. What about procedures for collection of patients with swabs for C. auris? There is a key step in identification of persons with colonization to help contain the spread of this. This is a document, you see the link here, outlines the procedure for collection of swabs from patients to assess for C. auris colonization. So this is out of CDC. You always want to follow institution guidelines for PPE and infection control when you're doing these things. But the skin, specifically the axilla, so the armpit or the groin region, appears to be the highest yield site to swab to identify patients colonized with C. auris. It's also been isolated from swabs taking from the nares. The nares, that's the nasal area, or the oropharynx down in the throat, perhaps the ear canal, the vagina, and the rectum. They continue to explore other sites that would help improve identification of colonized patients. This is an area that I work in or have worked in for for years with respect to MRSA, which is a resistant bacterial Staph aureus. And really it's helpful to know this because you want to, you obviously want to be swabbing and looking at the right sites that have the highest predictable outcome, the highest positive predictability, so that people know it's, the right way to kind of go for it. And then you have to be willing to pivot if that data changes. C. auris can spread from patient to patient. So we've mentioned that in healthcare settings like hospitals and nursing homes by direct contact. So, also may be spread by contact with contaminated surfaces. So this becomes a surface issue, perhaps with different types of medical equipment or surfaces, especially high touch surfaces like bed linens or curtains, things like that a person might be coming into contact with. It could also be from physical contact with another person, including sometimes healthcare workers who do unknowingly don't know that they've touched a patient who's colonized and they transmit it to someone who's more vulnerable. Patients have been found to be colonized for several months after the active infection has resolved, and we're still not sure the maximum amount of time that a patient can be colonized. Again, a lot of this is being worked out right now in the literature. So we're looking at surface viability. How long can C. auris stay on the surface? That's really important to understand because testing performed shows that it can really survive for weeks on surfaces. This happens with a lot of agents, perhaps up to 14 days. And so a couple of weeks. And so when you throw in the variable of a biofilm, that can also impact. So biofilms will be something we're talking about in the next stage of this talk, but here's a recent explainer article that I and Dr. Frenzy wrote. If you're interested in learning more, I would love for you to check this out. But you can think of a matrix being built up that's very sticky. This EPS matrix stands for extracellular polysaccharide matrix, a very sugary, sticky matrix, and it allows bacteria to kind of hide. I call it armor. So they put on this armor. It's a thick, gunky kind of level that attaches to surfaces. And then, as you can see in this picture, it allows them to kind of become hidden from antibiotics, from antifungals, even from your immune system. They can literally grow and divide in this matrix. And eventually this last piece of the image to the right, they can seed or dispense cells out into other places. So in theory, you could be hammering someone who has a biofilm infection from like a catheter that's going into your body. It's embedded there, and they may clear the infection because you're killing all the bacteria that are in circulation. As soon as you stop medication, that biofilm starts secreting that resistant bacteria to continue again. Another way to think about these, if you read this article, is I like to discuss this in terms of trench warfare. That biofilm is kind of a tunneling way of bacteria to kind of stay down below earth, and they literally can move around and evade your immune system or the types of weapons like antibiotics and drugs that you're hitting them with. So biofilms create an even bigger headache when you think about C. auris and other types of microbes. In fact, we know that they can exhibit a 10 to 1,000-fold increase in resistance when you're talking about bacteria that are just kind of living in a liquid environment. We've even done studies, other researchers, where they look at antibiotic-resistant Staphylococcus epidermidis in a biofilm. And if you're hitting them with vancomycin, which is a really big gun antibiotic, it will kill all of the isolates, 100% of them, when they're floating around in a normal environment called a platonic state. But when they're in the kind of submerged in that biofilm, 3/4 of them are completely resistant to the same antibiotic. So biofilms are really problematic for healthcare, especially when you mix them with antimicrobial resistance. So a quick transition here, pretty true in my world that sometimes these bacteria, these fungus, these other things just continue to evolve. They're always just a little bit ahead of us with respect to how they can hide. And so we have to definitely think about biofilms when we're talking about prevention and treatment. Strategies to prevent these in healthcare settings, because of their ability to resist killing by common disinfectants, persist and remain viable for months. Biofilms are notorious for for lengthening the ability of these things to hang around. Eradication, we need to eradicate things using novel disinfectants and other infection control measures before the infection takes root. Sometimes cleaning surfaces 2, 3, 4 times a day with a chlorine-based or other sporicidal disinfectant is highly effective in controlling cross-contamination. Again, all of that can be problematic depending on time. They do have an increased tolerance to biocides. We're talking about biofilms themselves. And so if you look at some of this data, there's a ton of data. If you look at this, 2 applications of bleach at 10,000 parts per million did not even eliminate the biofilm. Biofilms reduce susceptibility to UV. They're generally more effective against oxidizing agents, are more effective as compared to other types of chemicals like alcohols and quats. If it doesn't work on the biofilms, you're not disinfecting, right? You may even think you, but you're not. So those that are embedded, even the normal swab sampling may not get it out of there. You might have to do destructive sampling, which is kind of tearing up that biofilm. Remember, it's hidden in a trench. It's like trench warfare. So cleaning alone, people ask, doesn't that remove most pathogens? In this dry surface biofilm research study, studies found that dry surface biofilms on 93% of the surfaces in ICU, 52% of them had multi-drug resistant organisms following 2 rounds of cleaning. Privacy curtains, ward entry doors, mattresses, wire note clips. These are all high-level electron micrographs showing you biofilms, which is a fascinating microbial way of looking at things. If you ever get a chance to see that in a true microscope, it's fascinating to look at. Here's some SHEA, IDSA, and APEC practice recommendations to prevent HAIs through hand hygiene. This is a new paper. Pathogens of premise plumbing should consider disinfection of sink drains using an EPA registered disinfectant with claims against biofilms. And so this is a really important thing to consider these types of biofilm agents, because if you don't have them, you may not necessarily be cleaning. This is kind of a cool technology that helps detect biofilm, where they use a light method to detect bacteria living in the biofilm that can be missed with the typical ATP assay. This works on the fringe of the UV spectrum because it uses about 4 or more different wavelengths that kind of combine to detect the protein shell produced by bacteria. So it's a very targeted education and very targeted environmental swabs for people to start understanding how to detect these types of agents and probably others found in biofilms. This is kind of a cool image here to the right, kind of showing you that ability to see those different detection of biofilms. We also know that novel disinfectants, continuously acting disinfectants, including things like sodium dichloroisocyanurate, NADCC, to help penetrate biofilms are very effective. Look at this amazing slide here to the right. Pseudomonas aeruginosa and Staphylococcus aureus, notorious biofilm bacterial agents. And you can see after just 4 minutes of treatment with NADCC and a surfactant that we have basically 9 and 8 log reduction of both of these agents. And so a pretty good data showing over a time period after only 4 minutes. So again, kind of a continuously acting type of agent that can help eliminate that agent from the surface, kind of ongoing for time. Some new approaches we're watching. If you haven't heard of wastewater surveillance epidemiology, it's a WBE, wastewater-based epidemiology. You've heard about this during COVID, where we're looking at wastewater. We're doing different types of molecular testing to try to pick up different drug resistant or just novel agents. And so here in Southern Nevada, researchers are hoping their new study applying wastewater surveillance can help, officials get a step ahead of this emerging global public health threat. I think you'll see more of this type of technology going forward. I believe that is my last slide, and so I am happy to share this now with Nicole, my esteemed colleague.
Thank you so much, Dr. Rohde. That was an excellent presentation, and Nicole is up next. I know there's a lot of questions coming in. We're going to get as many as we can at the end, and if we miss your question, we'll follow up in writing and post them on the TIP site.
So thank you, and thank you, Dr. Rohde, for that excellent presentation. So we're going to start out with some of the cores of an EVS program as directed by the CDC. And first and foremost, does it integrate EVS into that plan? So I'd like to thank everyone for providing us the opportunity to share some of the best practices straight out of America's top hospitals. Every person matters, every patient matters, and thank you for your commitment to be proactive and help mitigate healthcare-associated infections before an outbreak occurs, including C. auris. The CDC provides us with general guidance, and I'll be walking us through exactly what this looks like in a hospital setting. We've got a lot to cover in a short amount of time, so please be sure to follow up after the webinar if you have any questions. So a science-backed EVS program is going to have some core components, and the program in its entirety is broken down into layman's terms. First and foremost, this program highlights EVS's role as an important members of the healthcare team, helping to keep vulnerable patients safe. They are our front line for helping to keep patients safe from what we cannot see, as well as those working in infection prevention. The most effective programs we've seen directly involve this messaging coming directly from the hospital's own leadership, who may just stop in to join a huddle in the morning, or who may take a few minutes to talk with EVS staff for a moment when they're on a patient floor. One of the hardest things I've had to hear over the course of my career is a staff member coming up to me after a training and just saying thank you. With tears in her eyes, she said, I've worked this job for 25 years and no one has ever told me how important I was to the patients or how I was helping them. Thank you for telling me. What's important for us to understand as trainers is that we may also need to provide a different perspective. Doctors, nurses, clinicians can see a patient getting or better or not after they've received a drug or surgery, and EVS just really doesn't know who they've helped or how they've helped. You've helped the patients that did not pick up an infection during a hospital stay, a patient who may not have gotten sicker from this, or who may not have died from a hospital acquired infection. So we have to recognize that those patients exist and are helped every single day and help them understand our role. The program will also review patient safety, infection prevention strategies, and discuss how pathogens can move and how they are spread in a hospital setting. It will review the science, the chemistry behind disinfectants that are used, and discuss safety and efficacy. Product training will include manufacturer's instructions. Demonstrations can include live demonstrations or videos of how to use specific products such as wipes, microfiber, microdenier, or something like an electrostatic sprayer, and may include ongoing floor training once the staff members are working with the product on the floors in the hospitals. So the CDC core components direct us to provide education, training, and feedback as components of cleaning and disinfection in hospitals. In best practice, we're utilizing a trainer to provide ongoing training and feedback in both classroom settings and on the patient floor. You want to make sure you're seeing in action on the floors what was taught in training. 100% of EVS staff should be trained on a core program, including an initial classroom or video training session of about 35 to 45 minutes. And this should include some time for in-person Q&A. And this is typically something that is in addition to the standard hospital program, or it will be integrated into part of the hospital onboarding program. Proactive training is completed as needed, and this will include proactive floor rounds, which are different from audits. And this gives us the ability to put out fires before they occur. So it's helping someone as they're needing assistance, they're having a challenge. It may be helping out in huddle trainings to provide some general feedback or general training. This can be one-on-one floor trainings. And then also the proactive training can be completed with compliance checks, such as EVS carts, closets, and discharge floors. So as we put this plan and program into place, we have to recognize that it may need to be adjusted for continuous process improvements. If the plan doesn't work, change the plan, but never the goal. Set the goal at 0 HAI outbreaks. It is time and it is achievable. 0 preventable HAI outbreaks sourced from any area covered by building services or EVS. So once we have a program in place, we now need to prepare for war with Candida auris. So know thy enemy. We know that C. auris can persist on surfaces and healthcare settings for several weeks and has the ability to persist in biofilm for longer, even up to months. On plastic, 14 days, and moist surfaces, 7 days. Know your space. What, where, and why. Walk the hospital with a fresh set of eyes and know what's used to disinfect what and why and where it is moving into and out of patient rooms and their point of contacts. What is moving into and out of patient rooms and their point of contacts? Well, glucose meters, blood pressure cuffs, computers, other rolling equipment. Are there shared spaces on patient floors? Was there an EPA P or K list plus product with a biofilm claim, product used or not used on that specific surface? What is being used on floors, glass, stainless steel? Look to improve patient areas with alternative products or disposables or hard surface alternatives for fabric that can be disinfected. We will also want to disinfect equipment immediately following use with an EPA or P or K list disinfectant, or a one-time use item is best practice. Are we covering nursing stations in all of the middle areas at least once a day? Are we also addressing soft surfaces? So that would mean changing out or removing patient room curtains in isolation rooms. And how about other cubicle curtains? Are we spraying these curtains at a minimum with a broad spectrum disinfectant and using a hard surface, high touch clamp that we can actually disinfect? So are we also using a house-wide sporicidal or a hospital-wide sporicidal? In selecting a disinfectant, it's important to understand how to read the labels, the claims, and the EPA list. So the EPA letter lists are performed with an isolate or planktonic cells in suspension to make claims on an EPA letter list, not cells taken from the natural environment that may be found in a protective layer of biofilm. So there are some shortcomings when relying on only the current EPA letter lists alone when we're evaluating disinfectants. Many common disinfectants do not have the ability to kill bacteria in a biofilm, but there is an EPA test for a disinfectant biofilm claim. This will be found on a product's master label. Are we considering dry surface biofilm in disinfection? So when we're choosing a more effective disinfectant for use in the hospital, we need to understand how different types of disinfectant chemistries work in the environment. And this enables us to choose the most effective solutions. So it is notable that this criteria is different from the level of disinfection that you can review on the properties of the ideal disinfection by the CDC. But we're looking to see if our product is checking all the boxes. Is it a sporicidal and on the EPA P list for C. auris or the EPA K list for C. diff? Does it work quickly? Does it have a rapid kill time? A rapid kill time of 4 minutes or less, and a total dwell time of 4 minutes or less. Does it have the ability to kill a specific pathogen? So this would be in the EPA letter list, plus penetrate a biofilm layer that bacteria form as a protective layer. And again, that's in the master label claim. Does it have an EPA emerging pathogen claim for COVID-19 and yet unknown emerging pathogens? And Dr. Rohde spoke a little bit about this earlier. Does it have a continuous active disinfection or residual efficacy beyond application for C. diff and biofilm? So that is also recommended by the CDC, is the CAD claim. Our programs based upon real-world evidence-backed studies. So back-to-scan images and lights are useful tools for education and for infection preventionists for environmental swabs. If a surface looks clean, it may still have pathogen. Looks can be deceiving. In this image, we can clearly see what looks to be a clean stainless steel water fountain and a bit of water on the surface. Under back-to-scan light, we can get a clear visual of what appears to be growth on the surface. Surfaces that look clean may still have colonies of pathogens if not properly disinfected. So back-to-scan allows us to visualize growth in biofilm on a surface that may look clean to the naked eye. A further step, even after cleaning the surface under a back-to-scan light, would then be to swab a surface for microscopic growth. So here we have a teaching hospital in the Northeast that did perform direct positive correlation between Candida auris skin colonization and environmental contamination. Samples were collected from a 70-bed ventilator unit, and as Rodney had mentioned before, this prevalence reached about 70%. Teaching hospital study in the Northeast. When we take and understand what Rodney went over earlier, Dr. Rohde, and we apply this to new studies, we're taking a look at comparative studies with disinfectants. We apply what we know about disinfectants and understand how they perform in an actual hospital setting. We can then go ahead and start to select our weapon of choice. So in this study, a teaching hospital in the Northeast in 2020 developed an environmental surveillance protocol to detect Candida auris, measure the adequacy of discharge room cleaning by different methods, including touch-free application using electrostatic sprayers. They swabbed 413 surfaces with peracetic acid and hydrogen peroxide. Study used a cutoff at food industry cleanliness standard to determine whether a surface passed inspection. So 7 rooms previously occupied by C. auris colonized patients were swabbed for C. auris contamination of environmental surfaces, including mobile medical equipment of the patient care units that contain these rooms, and no C. auris was found. The teaching hospital in the Northeast published a study in 2020 comparing 3 competing surface disinfectants following in between patient cleanings at 2 hospitals with a combined 1,082 beds. The study compared NADCC tablets versus peracetic acid and hydrogen peroxide versus electrolyzed water. 774 samples were collected from high-touch areas of patient rooms after discharge. Both peracetic and acid and hydrogen peroxide and electrolyzed water disinfectants were significantly more likely to have any growth on culture as compared to NADCC tablets. So the use of NADCC for surface disinfection resulted in the lowest bacterial colony counts on patient high-touch surfaces in this study. So as the CDC directs, we also need to take a look and see if we have simple and easy to follow protocols for cleaning and disinfection hospital-wide. So here's a good example of 2 very different EVS setups. The one on the left with 12 different chemicals, it's just complex and confusing, and there's a risk of chemical interactions. Protocols are seemingly non-existent. On the right, we can see a different setup with a single whole house or whole hospital multi-purpose sporicidal disinfectant with 2 dilutions, one for the floor and one for all purpose. It simply reduces the risk of chemical interactions, and the protocols are very clear. So when we're selecting an optimal disinfectant, what I think is important to note is that alternate disinfectants used during the COVID-19 pandemic can have potential impacts on health and safety. The industry is now well past supply chain shortages, and this is a question that we often do receive in the field, is what happens if we run out? So it's important to note we are now past this. Hospitals are now exhausting first wave stockpiles, where stockpiles are just in general expiring. So it is time to clear out stockrooms and closets and standardize with full house-wide sporicidal solutions. So here's another example of a very simple setup. This is a single disinfectant chemistry that is used hospital-wide. And whenever I'm taking a look at this, I always remember the words of my late organic chemistry professor, Dr. Rouse, keep it simple, smarty. In chemistry, we always remember to kiss. So very, very simple setup. This is the entire setup for a hospital of approximately 375 beds on a rolling cart. So are we proactively rounding and considering what we may be missing? The CDC's core elements tell us to monitor and adhere and provide to protocols and provide feedback. Are we proactively rounding though, and considering what we may be missing? An audit report from last week is not going to tell me what's going on with floor 19 West right now, where there's a new staff member who's confused about a product that is not EVS in a patient room. or EVS approved in a patient room. This is something that can be seen with rounding. So it's important to identify the potential sources of contamination in the environment. These can be bedside tables, bed rails, call buttons. We know all of these too well. We really do need to pay special attention to mobile equipment. And then are we using a P or K list disinfectant as recommended by the manufacturer? So this would include taking a good look at ultrasound machines, nursing carts, stations. Often we see in the hospitals that there may be an alternative type of wipe or type of product used with the clinical folks versus EVS. So is EVS coming through and covering the nurses' stations at least once at night? Glucose meters and charging strips. These sometimes may not be seen on the floor, might be in a different room, or a charging station may be set up in an alternate wing of a hospital. So take a look at where the glucose meters are and what they're being cleaned with, as well as the charging strips. That's very important because that's something you may not see from general rounding. Figure out where those are. Equipment charging stations, any type of equipment that's going back and forth or being used with the patients, you want to take a look at those. Thermometers, isolation rooms, you definitely want to use single use. Blood pressure cuffs, absolutely use disposables. Fabrics, soft fabrics, please remember to use the one-time use cloths in isolation rooms, or some type of a wipe that is disposable. So proactive floor rounds allow us to see something before it becomes a problem. Trainers will partner with EVS and actively work with supervisors, staff, and management on an as-needed basis to identify areas that need additional training and education. So what are the disinfection protocols for isolation rooms? This is a sample setup for an isolation room or an outbreak on a floor. What can happen during that time is we're going to have a special procedure for helping to prevent against cross-contamination and protect that staff member. So the staff member is going to go in and spray the disinfectant through an electrostatic sprayer before and after cleaning with a cleaner combination disinfectant using either disposable wipes or one-time use cloths. And again, this is very specific to isolation rooms or on a floor. So that, again, this helps protect the staff member, helps to prevent against cross-contamination, and it also helps to provide optimal surface area coverage for the disinfectant. So there are some special instructions for cleaning prior to disinfection against C. auris. For personal protection, we're going to wear the appropriate barrier protection, such as gloves, gown, mask, and eye covering. For fecal matter or waste, this needs to be thoroughly cleaned. All objects or all surfaces need to have disinfectant by application with a clean cloth, mop, or sponge. It needs to be completely saturated with the product. So pre-cleanings to involve vigorous wiping and scrubbing of all surfaces until soil is removed. Surfaces in patient rooms need to be cleared in an appropriate manner, such as from right to left, left to right, or in horizontal surfaces from top to bottom. Vertical surfaces to minimize spreading of the organism. We're also going to pay special attention to those. Restrooms are to be cleaned last. So that is something that I've noticed in hospitals. Some hospitals clean first, others clean last. In these instructions, we are saying that this is going to be cleaned last. Also, we are providing instructions not to, please do not reuse soiled cloths. So use one-time use cloths in those isolation rooms. Infectious waste disposal materials used in the cleaning process that may contain feces or waste are to be disposed of in accordance to local regulations for infectious materials disposal. So a large portion of what we do involves chlorine-based products. So we always do provide some tips for some chlorine-based chemical interactions. And just to understand if we're having a chemical reaction in the environment, it's always good to take care of that right away for patient safety and for the safety of the staff member. So how do you know that that's happening? Usually it's a quaternary ammonium compound interacting with the chlorine compound. So it's going to be something that you definitely will smell. It's other than something you're smelling other than a fresh, clean linen or pool type scent. If you notice the surface is sticky, has a strong chemical odor, your eyes are burning following mixing. J-fill water lines, and these are all suggestions to help not have these issues. J-fill water lines are known to leak disinfectant through the line, so use tap water only through a direct water source to obtain the water to mix chlorine-based products. And understand that all buckets, containers, mops, reusable wipes, and other equipment should be thoroughly cleaned, dried, or replaced with new when switching from quats to a chlorine-based product. If we do have a quat type product sprayed on a hospital mattress, it should be wiped with water only, followed by the application of the chlorine-based product. So earlier I discussed the 0 as a goal. I'll share one of our program partner updates. 0 is very much possible. And this is one of my absolute favorite phone calls from hospitals and what we work so hard for every day. This hospital implemented a science-backed EVS program in October of 2021, and it definitely did not start out like this. But from implementation date through April of 2023, we received the update call, 0 C. diff outbreaks, 0 HAIs and outbreaks under EVS, and 0 Joint Commission violations. So 0 is achievable. The supreme art of war is to subdue the enemy without fighting. So C. auris, are you ready for it?
Nicole, thank you so much. That was an excellent presentation going through how to implement those programs. Before we get to the Q&A, for those that are interested in CE credits, if you are interested, you'll be receiving an email from Terry Goodman. And if you're interested in the CE, complete the post-activity evaluation, and then you can download your CE from there. We've got a bunch of questions in the chat. We're not going to get to all of them. We'll publish the the Q&As on the TIPS website after. We have recorded the master series, and also you'll get a copy of the presentation if you're interested. The first question for Rodney: how do biofilms amplify the issue of antimicrobial resistance?
Yeah, very good question. So as I was mentioning earlier, biofilms are this really sticky polysaccharide matrix that creates this environment, really a very protected environment for bacteria, fungal agents, and probably other microbes that we're not aware of that live inside of this matrix that protects them from the bombardment of antifungals, from antibiotics, even your own immune system cells. And so what happens, and this gets into the weeds a little bit, is that bacteria in particular have the ability to share resistance genes through a process called conjugation. And so they are able to literally copy, for example, a resistance gene that would make vancomycin not effective against them. And they can literally share that horizontally with another bacteria, and not just another bacteria that's like them, but with a completely different bacterium. So for example, Staphylococcus aureus, through an appendage called a pili, it's like a little arm, can touch the arm of another bacterium like Enterococcus and copy over a resistance gene to vancomycin. And now you've got VRE, vancomycin resistant Enterococcus. So it's
pretty
a hard
stuff going on in biofilms.
Right. And so if they're in that biofilm, it just gives them the opportunity. They can do that anyway, but a biofilm gives them the opportunity to be protected from your immune system, from different agents. And so it just helps amplify that process for conjugation and the carryover of those types of resistance genes. It just really gives them a perfect storm to do so.
Great. Another question, Rodney, can you talk to us about C. auris with respect to why someone from the public could have misdiagnosis or incorrect diagnosis from a medical laboratory view?
Yeah, so kind of talked a little bit about it at the beginning of the presentation. Someone could potentially have that particular organism causing an infection or even a colonization. And if that particular healthcare entity, or think about your primary care physician where testing doesn't even occur, if they don't have the proper test to identify it, they might be treating empirically. So they may assume you have a bacterial infection, or they may assume you have a viral infection, and they may or may not prescribe an antibiotic. And so if you have C. auris, it's very easy. I shouldn't say easy. It's just a common problem where you just don't know if you're not using the proper test to identify a particular infection. And this happens across multiple bugs.
Excellent. Nicole or Rodney, do you want to take, you guys, you can see the, and before, as we're waiting, if anyone has any ideas, topics for another master series, get in touch with TIPS. We're happy to host and sponsor. This one's been very popular with spread of C. auris, but if you have additional ideas, we're happy to partner with you. Nicole, you have one? And then
Yeah,
we're going
there's
to
one,
probably have to wrap up.
Yeah, are you familiar with the hospital that looked at the 7, so I presented a slide earlier, the 7 positive C. auris patient rooms after terminal cleans with no positive findings in the patient room? And if yes, what is the disinfectant protocol this hospital is using in patient rooms today? So yes, very familiar with this hospital in particular. And we did present the sample or example isolation room slide. So they are using NADCC throughout their entire system actually today.
Great. Well, we're over the hour mark, so we're going to answer all the other questions, and we'll post those on the TIPS website. Thanks everyone for joining. And again, if you have any ideas for future series, let me know. And everyone have a great day.